Hello, I am Jolie Long with the National Board for Certified Counselors. On behalf of the Medicare Mental Health Workforce Coalition, we would like to welcome you to our webinar today. Next. Before we begin, I would like to share some meeting details. Closed captions are now enabled and attendees can turn these on and off as desired. Interpreters can join the meeting via the phone number, ID, and passcode provided on this slide. A link to this PowerPoint presentation will be posted in the chat so you can access the links on this slide. To receive continuing education credit, you must complete the session evaluation, including an attendance attestation. The link to the evaluation will be posted in the chat at the conclusion of the webinar. We will also send you an email with the link to the evaluation following the webinar. We will only be providing continuing education credit for live attendance of this webinar. The webinar will be recorded and made available on the NBCC website and other coalition member websites for viewing purposes only. Due to the large number of attendees, their participants will remain in listen-only mode throughout the meeting. We will be taking a 5-minute comfort break midway through this webinar today. The presenter will be taking questions at the end of the session, so please feel free to type your questions into the Q&A box at any time. Next. This is the 11th Medicare webinar that the Medicare Mental Health Workforce Coalition has produced. Please find information for videos of the previous presentations via the link on this slide. Next. The Medicare Mental Health Workforce Coalition consists of organizations that collectively represent providers, clients, patients, and other stakeholders. Our overall mission is to increase access to client choice for mental health provider care. Together, we achieve this goal with the passage of the Mental Health Access Improvement Act. The coalition is now working to ensure successful integration of counselors and marriage and family therapists into the Medicare program. The coalition members are listed on this slide. Next. Today's webinar is titled Normal Cognitive Aging and Dementia: What Counselors and MFTs Need to Know. We welcome an expert in working with older adults who will share information on normal cognitive aging versus dementia. In addition, she will cover how counselors and MFTs can apply this knowledge in the care of older adult clients. I would now like to introduce our speaker. Her full bio is in the slides for your convenience. Dr. Suzanne Musil is a board-certified clinical neuropsychologist in the memory care program at My Michigan Health in Midland, Michigan. Throughout her career, she has specialized in working with older adults with expertise in the differential diagnosis of normal aging versus dementia and dementia-related conditions. Dr. Musil is frequently asked to speak on this topic and enjoys educating patients, family members, and healthcare professionals on topics related to cognitive aging. Before Dr. Musil begins today, we would like to once again invite Erin Emery Tiburcio, a former speaker, to share some upcoming events of interest at the E4 Center that the E4 Center will be hosting. Afterward, Dr. Musil will begin her presentation. Erin?
Thank you, Jolie. Thank you all so much for being here today for this really important talk. I am honored to have had Suzanne as a colleague for many years now, and am well aware of her expertise in this space. And as she has been a part of the E4 Center, just wanted to say a couple of words for those of you who are less familiar with our work. Our mission is to engage, empower, and educate healthcare providers like all of you and community-based organizations for equity in behavioral health for older adults and their families. And on the next slide, you'll see some of our areas of focus include trainings on evidence-based programs. I'll share some of those with you in just a moment. Improving knowledge, skills, and attitudes. We've got an amazing learning community that happens monthly. Would love to share that with you. We've got some really great toolkits around building partnerships. And particularly those of you who are newer to working with older adults, there are some really great opportunities for you to build partnerships regardless of the kind of agency that you work in, whether you work for a clinic or independent practice, to begin to build those relationships with area agencies on aging and community-based organizations and the aging network, and really learning about who those organizations are that you should learn about. We've got some really great toolkits on our website. And we don't necessarily provide training directly to older adults and families, but we provide some really great resources for you all to be able to share. And on the next slide, you'll see that we are on LinkedIn and would love to have you come and join us. And this is typically where my program coordinator would drop a link in the chat. And unfortunately, she's not here with me today, so I'll make sure to get that link. On the next slide, a couple of our upcoming events. I mentioned our learning community. We are thrilled to have Dr. Teresa Ashman from NYU talking about aging and traumatic brain injury, understanding the intersection and implications. You might not know that folks with serious mental illness are experiencing high rates of traumatic brain injury, and this is really getting into the experience of aging as well. So please come and join us for that. And Dr. Sarah Qualls, who is a phenomenal educator and speaker, is going to be doing a 3-part workshop for us in September. So mark your calendars now. We'll drop this link, this E4 Center link into the chat to be able to register. So 3 Fridays in September, talking about caregiving in aging families, critical issues. I was just in the Capitol building yesterday educating congressional staffers about the importance of mental health in aging families. And so I am hopeful that we will have some legislation coming up to be able to support families who are aging. And one last piece for you to be aware of, if you haven't already, please come sign up for our Foundational Competencies in Older Adult Mental Health online certificate program. We have some really great resources for you there. We have a 16-hour online program for really inexpensive continuing education credits, or you can take the classes just for free to take the classes. And some of that content you'll see reflected here in Suzanne's slides today, as Suzanne was one of our core faculty members for the development of this program. So I'll drop some links into the chat to make it easy for you to access, but please do come on over and do that. And without further ado, I'm going to welcome Suzanne Musil. Thank you so much, Dr. Musil, for joining us today.
I think you have one more slide.
Oh, I do have one more slide. Thank you. Oh, my goodness. Because it's brand new, hot off the presses for all of you, those of you who joined us for the last couple of webinars on working with older adults. I did talk about Elder Speak, and we just created this fantastic guide for clinicians and for community-based organizations to be able to recognize some of the language that is not helpful for older adults and, quite frankly, for all of us as we age, because we are all aging, and it is critical that we think about how any of us would want to be spoken to. So I'm going to drop the link for this into the chat as well, and hope that you check out this anti-elder speak language guide that was created by my colleague Ashley O'Cray at Rush. So thank you for that, Suzanne, and we'll now actually hand over. Thank you.
Okay, I'm very excited to hear about this. I'm going to touch on elder speak just a little bit, so this is terrific. And I'm very excited to be here. Thank you so much for giving me the opportunity to share some information I know about cognitive aging with this group. So important that you're going to be able to start working more with older adults. And so I'm kind of thinking about this from the perspective of you're working with an older adult as a client, but you're also maybe working with some family members who may be caregivers of older adults. So this will apply to hopefully a wide range of what you do. So I don't have any disclosures. And my objectives for this presentation is, by the end of this, I'm hoping you'll be able to describe normal age-related change in cognitive abilities, differentiate between normal age, mild cognitive impairment, and dementia. And there's a lot of confusion about these terms, so hopefully by the end of this, that'll all be straightened out. I want you to be able to recognize the distinct memory impairment seen in Alzheimer's disease, because the way that presents is different from every other cause of dementia. Use appropriate communication for people with and without cognitive impairment or dementia. And then importantly, and I think this is particularly relevant for you all, to be able to assist older patients with making some lifestyle adaptations to reduce their risk of developing cognitive decline in the future. And so the outline for how we're going to achieve these objectives is I'm going to start with part 1 here on normal. We're going to stick with what's normal. So that'll include a very brief overview of brain anatomy and function. We'll talk about cognition and how that changes with normal age. And then part 2, we'll delve into the abnormal parts. And so this will be normal cognitive aging versus mild cognitive impairment versus dementia. At that point, we will take a 5-minute break and start back up after the break on treatable causes of cognitive impairment. And then finishing up with part 3 with just some general information about working with older adults. So we'll talk about communication strategies that would be helpful for older adults with or without cognitive impairment. And end up with, on a positive note, I always like to end on a positive note, with prevention. So I'm going to illustrate these points with a case. And this is an evolving case that will weave throughout the presentation. And so this is Janet. Janet is somebody I made up, but I've worked with Janet for a long time now, so she feels very real to me. And so Janet's seeing you for the first time. She is 76 years old. And a little background information about her: she is a retired school teacher. She was married for 53 years, recently widowed. She has 3 children, 5 grandchildren. She loves to read, cook, and garden. So she's a pretty active lady. And what she's coming in for is her husband died not too long ago from cancer, and she was his caregiver. So she's done a lot of her grieving already. She's not depressed necessarily, but you're seeing her for adjustment to widowhood. You know, as a couple, they had a lot of shared tasks, and she's kind of at loose ends, like how to get back to doing things just on her own. So it's more of an adjustment type of issue. Her medical history includes high blood pressure, hypertension. She has borderline diabetes. Her cholesterol is a little high. She has some arthritis, and her thyroid is low. And the medications, how these conditions are being treated: she takes lisinopril, that's a medicine for high blood pressure. The levothyroxine is for low thyroid, and ibuprofen for the arthritis. And so what you see here is that her borderline diabetes, the cholesterol, are not enough that she needs medication for. So those are being managed pretty well right now by diet. And I did also want to point out that she is a non-smoker, and she uses alcohol pretty rarely, like on holidays or major social occasions. So as you're getting to know Janet in this first encounter, there's 2 kind of things to alert you to when you're thinking about cognitive decline or potential cognitive decline in an older person: is what's their cognition like and what's their function like. And this will become apparent, the importance of these 2 areas as we go along. So cognitively, she tells you that, you know, her memory's not been so good the last couple of years. She was kind of chalking that up to stress. She wasn't too concerned. The things she reports are like, what did I come into this room for? What did I get up to do? She misplaces her glasses, but she finds them after not too much of a search. And she sometimes has trouble coming up with the words she wants to use. So those are her only cognitive concerns. And functionally, she described herself as fully independent. And based on your initial encounters with her, you had really no reason to doubt her report of herself. She makes all the appointments with you on her own. She never misses sessions. So she seems functional. And she also seems to have pretty good carryover between sessions. You know, sometimes you might need a reminder of something that you talked about briefly in a previous session, but overall she has pretty good carryover. And as you're working with Janet in these initial sessions, you talk to her about what matters to her. And what she is able to identify is she would like to be self-sufficient. You know, she wants to be able to do for herself all those things that her husband used to do with the task sharing. She wants to stay as independent as possible, in particular, so that she can play an active role with her grandchildren. And here she is with her oldest grandchild, who is the apple of her eye. He was named after her husband. She just wants to be them to know her, and she wants to be really involved in their lives. All right. So as we go through the next few slides, I want you to be thinking about Janet and be asking yourself, is what I described normal for 76, or is it abnormal? All right, so let's talk about what's normal. Now, what I have here is a line drawing of the left hemisphere of the brain. The front of the brain is to my left, and the back of the brain is to my right. And from a broad, very broad perspective, the brain can be divided into large territories called lobes. The lobes are named for the part of the skull that overlies them. So the back of the brain is under the occipital bone, so it's called the occipital lobe. In front of that, we have a large territory called the parietal lobe. And then underneath there, we have the temporal lobe, which is under the temples. And then the largest area of all in humans is the frontal lobe. We're going to be talking about the frontal lobe in more detail. This is an important area for our purposes today. Now, if you were within that, so those lobes are just sort of very broad territories based on anatomy. There's many, many, many functional areas within each lobe. But again, staying from a broad perspective, the back part of the parietal lobe here deals with visual spatial abilities. What that means is visual spatial abilities are something the brain does that we don't really think about. So the brain is just always aware of where you are in space, where things are around you, where objects are around you in relation to each other. And so that would allow me, for example, to reach over here and pick something up while I'm looking in the opposite direction, being able to plan my arm movement to line up with the object I'm reaching for. So all these things we don't have to think about. It's just kind of automatic. So that's what's meant by visual spatial. Language is a very distributed function. It involves a lot of different brain areas in frontal, parietal, and temporal lobes. Memory is done by some structures deep within the temporal lobe. And then lastly, this largest area of the frontal lobes deals with what are called executive functions, which I'll talk about in more detail in a minute. And they're also responsible for our behavior and personality, kind of like who we are. Now, if you were to take this brain and you're going to make a cut that's horizontal, parallel to the floor, take the top off and look down on it from above. So there's a cut. We're going to look down on it from above. Now the frontal lobes are at the top here. I drew that other brain. I never got around to drawing this one, but so this is an MRI scan. And what you see is a lot of light areas and dark areas. So the dark area that kind of winds around the outside here is what's called the cortex. Cortex means bark, so the outer covering of the brain. This is where all our conscious thought processes take place. So all of our thinking abilities that we're aware of are done in the cortex. Underneath that, you have all these, this large white area, and that's what is called the white matter. So gray matter, you have brain cells. The body of the brain cell is in the cortex, and then it sends a connection through the white matter to all the other, to different brain areas. So this is what connects different brain areas to each other. So you can think of these as kind of like the information highway. So they don't process cognition per se, but you'll have a cognitive problem if you have a problem with the white matter because the connections have been damaged. So how does the brain age normally? Well, first off, normal is hard to define. Not everybody starts at the same place. There's lots of variability in terms of, education, medical status, early childhood illnesses, just various sorts of things. Not everybody starts at the same place. And then secondly, we see the same exact changes in normal aging and disease. So that can make it really challenging to say, what is this normal amount for age or is it abnormal? So what we do see is that there is a loss of brain volume that's called atrophy. So we lose brain cells, the brain shrinks. There are also changes in that white matter that I was just talking about. So we lose some connections between brain areas. And there's also vascular changes with the blood supply to the white matter and other areas, and reduced blood flow generally. And most of these changes are seen in this frontal lobe area that I was talking about. So let's talk about that in a little more detail. The frontal lobes are responsible for a class of thinking abilities that are called executive functions. The way I like to explain it to people is they're called executive functions because they're the abilities, the thinking abilities that let us execute appropriate behavior for whatever situation that we're in. So what the frontal lobes do, they have a very prominent role of the frontal lobes is to monitor what I'm thinking, what I'm doing, what's going on around me in the environment, and just making sure that everything's on track. And if it's not on track, to do something different. So that involves a lot of high level thinking, being able to plan, solve problems, think flexibly, organize information, reason, use judgment. And these are just a handful. If you were to Google executive functions, you'll get a list that probably has 20 different cognitive skills on it. So it's a very complex area of thinking. The frontal lobes also assist with memory. So let's talk about memory next. So what I'm going to be talking about with memory is just our ability to learn and remember new things. And the first concept to get here is that memory works in stages. That's an important concept because each stage then depends on the stage before it working properly. That puts a lot of pressure on the first stage here, because if you have a problem here, it's going to affect everything else. So the first stage is what's called encoding. This is what you can consciously hold on to and work with. So most of you are attempting to encode information right now as you're listening to me. So you're thinking about it, you're paying attention to it. But this is just the temporary processing. If you're going to remember this later on, your brain has to take it and put it into long-term storage. And this is really what we mean by memory, being able to make a more permanent record of something. But even once it's in long-term storage, to remember it later, you have to retrieve it back out again. You have to retrieve it out of storage. So you'll notice I have these two stages up here on the same level together because they're alike in a couple different ways. And the first way, or the most important way, is that they're done by the same part of the brain. Now, hopefully trying to use a strategy here to facilitate learning. So this is color-coded. So the encoding and the retrieval stages are what the frontal lobe does. And I put the white matter up here too, because as I was talking about those executive functions, being able to behave appropriately in the situation, the way the frontal lobes can do that is they're receiving information from the whole rest of the cortex, and that information is coming through the white matter. So the frontal lobe relies on the white matter to be able to do its job. So if you have a problem with white matter, it'll cause also problems with executive functioning like the frontal lobes would. So as I mentioned, the frontal lobes are the first area to decline. I'll say they're the last brain area to fully develop and the first to decline with normal age. So they're not fully developed until around age 25, and they start to decline in your 40s. So you have a small window of good frontal lobe function. So because the frontal lobes change with age, plus some other kinds of dementia, but we're going to stick with normal age for now. This is the type of memory problem you would see with normal age, whereas the storage stage is done by the temporal lobe of the brain. This is where Alzheimer's disease typically starts. So you have two different kinds of memory problems depending on where in the brain the disease starts. Now, the other thing, and I did want to say, for those of you who have the slides already, I have added a couple, maybe deleted one or two, so they're not exactly the same as the ones you have, but this is a new one. So the other way that these encoding and retrieval stages are alike is this is what you're thinking about in the present moment. So you're encoding, you're thinking about something right now. After this webinar, you'll stop thinking about it. Some stuff got into long-term storage. It's out of sight, out of mind. But if somebody asks you about it later on, you're going to retrieve it back up into that present moment. So this is what we're doing in the moment, and that makes them very dependent on attention. And this is a concept I'll come back to later. I just want to introduce that now as another way that those two stages are alike. So we have two types of memory impairment based on anatomy. With the encoding and retrieval problem, information is harder to get in. It's a little harder to get back out again. This is normal for age. And as I said, those changes start in your 40s. The storage stage, new memories are not being made. Information never gets stored permanently, so it's just gone. And this is never normal, never a normal part of aging. All right, so that's memory. And just taking a bigger overview of what you might see with other cognitive abilities with normal age. With attention, so attention is also a very complex ability. It's kind of hierarchical. It's just at the very basic, can you just pay attention and listen to something, stay awake? Getting to more complex thinking, like being able to shift your attention or selectively attend to this and ignore that. But the basic attention abilities may remain intact. What does change is the speed with which we can process information. So processing speed slows down with age. And this is an important concept because the speed with which information comes is important for a lot of other skills. So for example, if information is coming at you rapidly, you might not, and your processing speed is slow, you might not remember it very well because it just came too fast. Executive functions. So the frontal lobes change with normal age. So executive functions definitely do change with normal age. Some aspects are preserved, but there is decline in many aspects, like being able to think flexibly. Language. The only thing you'll see that's normal for age is some word retrieval problems, that tip of the tongue sort of thing. That's normal. Otherwise, language is preserved. People can understand, express language. And in fact, some aspects of language improve with age, like being able to, vocabulary in particular. And then lastly, visuospatial abilities, those are stable with age. All right, so things that are not normal. Problems sustaining attention, that's never going to be normal. That suggests something else is going on. Certain kinds of memory problems, so like the storage problem, for example, that's never normal. Not being able to understand or express language, so not just difficulty coming up with words, not knowing what things are, not being able to understand a more complex sentence, that's not normal. And of course, visual spatial problems are not normal because those stay stable with age. And also significant changes in personality and behavior. And so I say significant, sometimes older adults can be described as like being maybe more of the same. So if you were a little stubborn when you were younger, you might be a little more stubborn when you're older. But if it's an abrupt, like about face change in behavior and personality that includes like being socially inappropriate, exhibiting very poor judgment, lacking awareness, that is not ever normal for age. All right, So as we kept Janet in mind as we were going through this, I'm hoping I illustrated her well to you that what she was reporting to you is normal for her age. All right. So as this first encounter progresses, you work with Janet for about 4 months. So you're seeing her for adjustment to widowhood. She makes good progress. You terminate treatment. So you had a nice, successful encounter with her. All right, so Janet is normal. So let's talk about the abnormal stuff. How do you get from normal to dementia? So what I have illustrated here, and just so you know, I routinely draw out this graph for people to explain this concept because everybody is confused about this. I get all the time, what's the difference between Alzheimer's disease and dementia? So hopefully this will explain that and help you be able to explain it to people you're working with. So this is time down here on the x-axis. So this is just a person's life until they die from whatever they die from. And on the y-axis over here, we have their cognitive abilities. So all those memory, executive functioning, etc., going from poor to good. So there is some decline that's normal for age, which we just talked about. And the older I get, the less steep this line gets, but it's really not that terrible. There's definitely some changes. But some people decline much, much more. And at some point, and it's really kind of arbitrary, but at some point we say, you know what, this person can no longer do their daily activities. And that's when the label dementia gets applied. The reason it's arbitrary is like, how do you define daily activities? Not everybody, not being able to bathe oneself is an activity, but it's very different from being able to pay bills or do finances. And so not everybody has the same level of activities to start with. But at some point, they have enough cognitive impairment that it interferes with daily activities, and now they meet criteria for dementia. But what you see is there's this whole period of decline in between the normal and dementia, where people are having problems, but they're functional, and that's what's called mild cognitive impairment. So dementia is best thought of as an umbrella term. With just those two criteria, there's a significant decline in cognition or behavior, and it's from a previous level. That's an important concept. And that interferes with a person's ability to carry out daily activities. So the diagnosis is confusing because essentially you've got these two things that sound very different, two different names, but they're different names for different stages of the same disease. So someone might say, oh, I only have MCI, that's good, I don't have Alzheimer's disease. It's like, no, you could have MCI caused by Alzheimer's disease. So what we now know is there's this kind of trajectory where a disease like Alzheimer's disease can be present in the brain back when someone is completely normal. And that it could be 10, 20 years before anything shows up. So there's a preclinical phase. That's recognized now, but the term MCI was originally conceptualized, and it wasn't that long ago in the grand scheme of things, was conceptualized to reflect a pre-dementia stage of Alzheimer's disease. So someone can have Alzheimer's in their brain and they're normal, and then they start to have memory problems. Now it's MCI due to Alzheimer's disease. And then their function becomes impaired. Now they have mild dementia due to Alzheimer's disease, then moderate and severe dementia. So it's one disease. These are all different names for different stages of the disease. It's very confusing. So MCI was originally conceptualized to reflect pre-dementia stage specifically of Alzheimer's disease. But of course, any dementing process, any neurodegenerative disease will have a corresponding MCI component, which is the stage between when they are cognitively normal and when they exhibit functional impairment. So MCI is a risk factor for dementia. And I didn't want to load you up with statistics, but about 15% of people with MCI will progress to dementia in 2 years. 67% will progress to dementia in 5 years. So that leaves a chunk of people still with mild cognitive impairment, but most importantly is that 26% go back to normal. Okay, so it's a risk factor for dementia, but just having MCI is not 100% the case that you will progress to dementia. All right, some other ways in which dementia diagnosis is confusing is the diagnosis can represent, the terminology is terrible. So the diagnosis can represent the disease. So we talk about Alzheimer's disease. And as we just learned, that could be somebody who's normal, someone who has MCI, someone who has dementia. So Alzheimer's disease, vascular disease, those are the two I'm going to be talking about today. But sometimes the label you get is where in the brain the disease starts. So not going to talk about this cause of dementia, but there is a type that starts in the frontal and the temporal lobes. That's called frontotemporal degeneration. And so this is an anatomical label for what's going on. And then lastly, the diagnosis you get might be the clinical presentation of the disease. So a primary progressive aphasia. And the bottom line is actually all three of these might be correct. And so this was exemplified in, if those of you who have kept up on any celebrity news with Bruce Willis. When he first came out, he was first diagnosed with aphasia, okay? And then it was dementia. And the way it was presented in the news, it was as if he had aphasia and dementia, like two different conditions. What it was an aphasia that progressed. So an aphasia is an acquired language disorder. And I believe his was being able to express his language. And then as it interfered with daily activities, now it's a dementia. So it's a primary progressive aphasia affecting the frontotemporal lobe. So he has that's called FTD. So he has FTD. And the cause could be Alzheimer's disease. So all three of these might be accurate. So it's no wonder people are confused. The bottom line is what a disease looks like early on correlates with brain anatomy, not with pathology. And this is the challenge we're at right now, is because clinically we only can see what people look like clinically, and that doesn't always line up with the pathology that's causing the problem. And I did want to just briefly introduce the concept of a focal versus diffuse. And what that means is, so if you have a disease that starts very specifically in a particular part of the frontal lobe, it's going to cause a language problem. So it's very focal, it's just the language. Whereas another disease might start in multiple places kind of at once. And so it's more of a widespread diffuse kind of pattern. What that means clinically is if it's a focal disease, which Alzheimer's disease is typically focal, what that means is almost everybody who has it is going to look the same because the part of the brain that's affected is the same in everybody. So there's a lot of similarity across people with early Alzheimer's disease. Whereas when something starts more diffusely, it could be starting here with one person here, somewhere else. And so they might have the same disease, but they could look very different. So not everybody with a diffuse disease looks like everybody else with a diffuse disease. All right, let's go back to our two types of memory problems. The storage stage People have the inability to make new memories. What that means is, and this is also a concept when you're talking to memory about memory to people, is what kind of memory are you talking about? So they will say, oh, my memory's great. And they talk about how they can remember all these things from 50 years ago or 40 years ago. And then you ask, well, what did you do last week or yesterday? And that's where the memory problem is. So the way to think about this is if you're talking to somebody at 75 and they got Alzheimer's disease at 70, or it started showing up at 70, during that period between 70 and 75, their brain isn't making new memories. So their memory for things that happened to them recently is going to be poor. But things that they stored long before the disease started, those are going to be okay. So it's a problem with recent memory that Alzheimer's disease causes. So the memories made previously are preserved. And then another important aspect of this type of memory problem is that people have little to no awareness or insight into the problem. And if you think about it, it kind of makes sense. So to them, something happened and it never got into storage. To that person, it's as if it didn't happen at all. It's not, in fact, when we say, I forgot, we've really just remembered. We haven't truly forgotten. And so when your brain isn't making new memories, it's as if those events never happened. And I'll see all the time someone, an adult child will be telling me something, and then the parent goes, I didn't do that. Did that happen? Or it's like, so-and-so died. I didn't know that. So they'd have no awareness of it. Encoding and retrieval problems, on the other hand, memories do get made, but it may be inefficient or inconsistent. So in particular, what happens with normal age is memory gets a little less sticky. When we're younger, especially like kids, memory is sticky. They hear something once and it's in there. It's stuck. It's good. And memory gets a little less sticky as we get older. And so if you have to make some more conscious effort to get information in. So it's inefficient, it's inconsistent, but typically the important stuff, the things that are important to that person, they get in. It's the maybe some of the minor details that go by the wayside. Because they have retrieval problems, giving them a hint or a cue can help them remember it. And because they can store information, they're usually aware of the fact, like, I know this, it's in there, and I just can't get it out. So they're often typically very aware of the memory problem that they're having. And just, as an aside from my clinical experience, it's very rare that a person coming in on their own, an older adult, it's very rare that they end up having Alzheimer's disease, maybe sometimes very early. But the ones who are coming in on their own because their memory is terrible, it's usually probably encoding and retrieval. All right, so what does Alzheimer's disease look like early? So my experience as a neuropsychologist is in the kind of diagnostic phase. I don't work with people who are in moderate to severe stages of dementia. At that point, when more of the brain is involved, the distinctions between different diseases is gone by the time the disease is advanced. So where the different diseases, where they look different, is early on. So with Alzheimer's disease, it's the most common by far of diseases in 60 to 80% of the cases. The cause is abnormal proteins that accumulate and cause cell death, so atrophy. And those are called plaques and tangles. So here is a healthy brain on the left here, and severe Alzheimer's on the right. You can see how much shrunken that is in comparison. And I do recognize that you're not going to be able to see this slide as well, but these are healthy neurons in the purple here. And then what develops is abnormal proteins of amyloid collect in plaques, these are the big blobs here. And then what are called tangles made up of a tau protein develop inside cells. This is what makes Alzheimer's disease, why treatment has been so tricky, is because there's two pathologies. There's amyloid and there's tau. But both of them, the bottom line is they interfere with the cell's ability to communicate, and they cause them to die. It starts the vast majority of the time in temporal lobe memory centers. So it's a focal presentation causing a memory storage problem. So they'll have poor memory for recent events. Naming, language is done in the temporal lobe too. So naming problems and word finding difficulty is also very common early on. The word finding is much more pronounced than you would see with normal age. And the naming problem is not just not knowing what something is called, but when you tell them what it's called, then they might kind of go like, oh, is that, kind of like they don't even recognize the object. Lack of insight is a key feature. Vascular disease, on the other hand, is very different. So vascular disease is very common. It doesn't always cause dementia, but it's common as causing cognitive problems. And there's two causes, one of which is focal and one is more diffuse. So here is our MRI scan that I showed earlier with all the white matter here. If someone has a focal, if they have a stroke, let's say on the left frontal lobe, that could cause a language problem, then that's, if it's a small enough thing, they'll just have a specific kind of problem. But more often what we see is a picture like this, where now all these bright spots are vascular disease in the brain. So what happens is the blood vessels, when they're in your neck, they're actually pretty big. And as they come up around the brain and penetrate into the brain to feed these deep brain areas in white matter, the vessels get smaller and smaller, because otherwise it'd be poking big holes through the brain. And the walls get thinner and thinner. So they're susceptible to just wear and tear from age, but also to tearing and leaking from things like high blood pressure and diabetes. And so it's affecting all these areas kind of at once, and then it builds up all at once. So this is a much more diffuse picture. And this is the most common way we see microvascular ischemic disease is ischemia is just a disruption of blood flow, and then microvascular, so it's a disruption of blood flow in the tiny blood vessels. So it's associated with high blood pressure, diabetes, high cholesterol, heart disease, all those things. But there's other risk factors. So the point there with the high blood pressure and diabetes, vascular disease is going to be more common in people for whom those diseases are more common. And in this country, that's Black Americans, Hispanic Americans, Native populations. But there are other risk factors, including smoking, obesity, and just age because of wear and tear. So anybody can develop vascular disease. Because it's a white matter kind of problem, it affects memory encoding and retrieval. And as I mentioned before, the white matter you can think of as the information highway. Well, this vascular disease has put a lot of potholes on that highway. And so you can still get to your destination. The information can still get to its destination, but it takes a lot longer. The frontal lobes are being deprived of some of its information because of the white matter damage. And so executive dysfunction, that difficulty with planning, problem solving, mental flexibility, that's seen in vascular disease. So unfortunately, a person can have both Alzheimer's disease and vascular disease. And in fact, having a mixed etiology is more common than having a pure one. But together, these two represent about 75% of dementia cases. And that's why I wanted to focus just on these two, because if you can recognize those, you're going a long way towards being able to tease things out. And then also you would be able to know when things don't fit either of those things, that something else is going on. Maybe it's one of the other 25%. All right, so as we go back to Janet, this is our, again, you're having a second encounter with her. And so this is 6 months after terminating the first treatment. And the reason she's contacting you now is she wants to start treatment again, is that unfortunately what happened is that grandson, who was the apple of her eye, was killed in an accident 2 months ago. And she comes to you saying, I'm depressed. I'm highly depressed. And in addition to being depressed, she's not sleeping well. She's got poor appetite. She lost interest in doing her cooking and gardening. And she neglected her health for a couple of months. So her blood pressure is now out of control. She's gone from pre-diabetes to diabetes. And now her cholesterol is high. It's not just kind of maybe a little bit high anymore. So she's in a different situation than when you first met her. Her daughter began stepping in to kind of help out and get some things turned around for her mom. So now what she looks like cognitively is she feels like she's losing it. She's like, I think I'm getting Alzheimer's disease, so forgetful. She repeats herself all the time. She frequently misplaces things and can't find them for a long time. So she's reporting a really significant change. And then functionally, so our other domain to assess when we're thinking about dementia, there's been a decline. Her daughter has to oversee her medications now. Makes her appointments, brings her to sessions. You're allowed, talk to the daughter a little bit. And what you notice is now she's very different. She's much more forgetful about the session content than she was the first time you saw her. All right, so where are we now? What's going on now? Is this normal? Well, we can rule that out right away because she says she's different. The daughter says she's different. You can see she's different. So this is not normal anymore. Is it MCI? Well, that technically should be ruled out, right? Because she's got cognitive impairment and functional decline. So that should be dementia, right? No. Why not? Why isn't this dementia? I just told you that those are the two criteria for it. And this is a really important concept, is that we don't diagnose a chronic condition in the presence of acute factors. So based on what you've learned from Janet when she comes back, she's depressed, she's lost interest, she doesn't sleep well, she's lost her appetite, she's got cognitive impairment, she's got a major depressive disorder. So that's an acute condition that wasn't present before. And that is a cause of cognitive impairment that's treatable. So the depression is treatable. That means the cognitive problems that are due to it are treatable. So this is where we will I apologize. This is where the slide break is supposed to be in, and I don't have it in here. I apologize. But this is where we'll take a short break to use the restroom, get a drink of water, and then we'll come back in 5 minutes. Thank you. Okay, so we will get started again. So we left Janet with a major depressive disorder and a lot of memory problems. So it's a nice segue to talk about the causes of cognitive impairment that are treatable. And there's a number of them. So we'll start with depression, since that's what we were dealing with Janet. If you're familiar with your DSM-5, almost every psychiatric diagnosis you can look up in Access 1 anyway, has a criterion of cognitive impairment. Problems with attention and concentration or memory. So depression, generalized anxiety disorder, PTSD, a lot of things. And this is where that concept I brought up towards the beginning about the encoding and retrieval stages being dependent on attention and being present moment, that's where this comes in as important. And so when you have a condition like that, it causes what you can think of as an attention-based memory problems. You can't remember what you didn't pay attention to, right? And so things that take attention away from the moments that someone is in is going to cause an encoding and retrieval memory problem. And the things that do that are things that you work with every day. Anxiety, depression, fatigue, poor sleep, pain, just feeling ill. None of us are working at our best when we don't feel well. And in particular, my experience when anxiety and pain are extremely strong stimuli that say, pay attention to me. And so when someone's attention is caught up by not being able to ignore this pain or other kind of condition, then their attention is reduced and they're going to have memory problems because of that. So if a mood disturbance is present, you want to do an age-appropriate mood screener. So something like, for Janet, maybe the geriatric depression scale. Nutritional deficiencies can cause cognitive impairment, in particular B12. And so medical workup is always done early on when someone begins experiencing memory problems to make sure that there's nothing easily fixed like that, like a vitamin deficiency. Obstructive sleep apnea. Now, it may just be a coincidence. I moved up to Michigan about 1.5 years ago, but everybody I see now has untreated sleep apnea. So I don't know if that's Central Michigan or it's an increasing problem. But what happens is with sleep apnea is a person stops breathing during their sleep. The brain doesn't get oxygen. Sleep is where memories are made. So they have memory problems. And they can be very pronounced. I've seen people who test in a dementia range, their memory is so bad. And then memory for untreated sleep apnea, memory improves after 3 months of consistent CPAP use. So it takes a while to get back to normal, but you can. And then delirium, we're going to talk about in a little more detail because this is also unrecognized, misunderstood condition. At its simplest, it's just an acute confusional state due to a medical condition. And what it is characterized by a variety of disturbances. So consciousness is disturbed. People may not be alert or arousable. They're disoriented. And it can be wildly disoriented, like it's 1952. Perception is disturbed, so they may have hallucinations. Sleep-wake cycle is disturbed. They're awake at night and asleep during the day. Thought processes are derailed. They may be tangential or just nonsensical. Delusional behavior is disturbed. Sometimes people will become very quiet and withdrawn. They might look depressed. Versus being agitated and pulling out IVs. So a lot of different ways that can present. And then cognition is disturbed. And since this is the point of this presentation, I'll talk about that in a little more detail. So what delirium presents with is what you think of as just a profound attentional disorder. It's like nothing, it's like a major fog. Nothing gets in. And because we need attention to do pretty much everything else, it's going to affect all of our other thinking skills. So there's a lot of cognitive impairment. Memory's impairment is impaired because they can't pay attention. They can't process information. So it's an encoding problem. Information just does not get in. A lot of things will predispose somebody to developing delirium. Risk factors, so in particular older age. So this is delirium can happen at any age, but it's much more common as we get older. If there's baseline cognitive impairment, so cognition is already a little low, it doesn't take as much to set it off. Having a functional disability, sensory loss, this is a particular issue in hospital settings if people don't have their hearing aids or glasses with them. And having multiple coexisting medical problems. So all of these things will make it more likely for somebody to develop delirium. And then what sets it off, a whole bunch of things with medications being number one. And older adults are more likely to be on more medications. And so that's why it's also an older adult thing. But going into surgery, having an anesthesia, being in pain, having an infection, in fact, urinary tract infections in older women is a very common cause of delirium. Any sort of acute illness. I mean, it's a really long list of things that can trigger delirium. And in older adults, this is a much more frequent and more serious problem. And that's in large part because it goes unrecognized a large part of the time. The biggest issue is that it occurs with less provocation. And this is why it's so important for our healthcare workers to have geriatric training, because you can't view that older adult through the same lens that you view a 30-year-old. So a 30-year-old, it might take liver failure, something very severe to cause the delirium. With an older person, it could be multiple small little problems, none of which kind of are a big deal on their own, but together they add up. And in particular, the issue that is different with older adults that contributes to under-recognition is that it develops more slowly and people recover from it more slowly. So take our 30-year-old with liver failure. Their liver fails, they become delirious, so they're confused, disoriented, hallucinating. They get the liver squared away in a day or two, and then in a day, so that their delirium developed in a day or two, and then the liver gets treated, and then a day or two later, the person's better. That's not how it works in an older person. So here's just a little schematic example of how this might work with a younger person. With the older person, that gradual decline into delirium is much slower. So instead of a couple of hours or a day, it might be a couple of weeks even. And then let's say they're recognized around this phase, and then their urinary tract infection gets treated, but they might stay confused for much longer. And there's less of a tight link between the treatment, between the onset of the problem and the treatment in terms of the recovery. And so the recovery may be much slower, more gradual. I've seen people in their 80s who took 3 months or more to recover from their delirium rather than a couple of days. And so it's these periods, this slow kind of buildup and the gradual recovery, that's they're not actively delirious, so they're not hallucinating, may not even be in the hospital in those stages, but they're confused. And that's where misdiagnosis happens. They get misdiagnosed as having depression. So the person who is quiet and withdrawn, people misdiagnose them as depression, or they get misdiagnosed as having dementia. And that's a very critical point, because when misdiagnosis occurs, that means there is a medical problem going on that's not being addressed. So there's a very high mortality rate associated with delirium in older adults. And unfortunately, some older adults don't ever recover back to their baseline. So early recognition is really critical. So to help you kind of just be aware of that issue, any kind of abrupt or semi-abrupt, so I'm talking about change that occurs over a couple of weeks. Dementia, outside of some very rare things, dementia doesn't go that fast. So you want to consider a medical etiology before dementia diagnosis in those people. Ask your clients about all the medications that they're taking, especially if there's anything new. So medications are the #1 trigger for delirium. And you have to cover both prescription and over-the-counter vitamins and supplements. Sometimes those things can interact with prescribed medications, and people don't always tell their doctor about them. Ask your patient, does the person get all their medicines from the same pharmacy? I saw somebody recently who got half of his meds from the VA and half from a Walgreens or something, and those two pharmacies don't talk to each other, so potential interactions are going to get missed. You can also check the American Geriatric Society Beers criteria. So as you start working with older adults, I would just suggest, as you look at their to ask about medications, and then as you look at them, you're going to gradually kind of acquire a list that you keep in your mind of ones that are bad. I'll tell you one right off the bat is Benadryl, diphenhydramine, over the counter, causes confusion in older adults. And so if you have a question about a medicine that was added recently, you can look it up. And if it's on this list, it'll tell you whether it's an inappropriate for an older person to use. Are all the medical providers in communication with each other? So I'm in Central Michigan. We have one medical system. There's a lot of patients here who are not in my system, and they come in here and I don't know anything about them. So electronic medical records are helping a lot with that, but there are still some areas of lack of communication. And you just want to become comfortable, within the bounds of your profession, being able to discuss with a primary care doctor. It's like, hey, I've noticed so-and-so's memory seems to be a little worse, and wonder if you had any ideas what that might be, or the medications. Just bringing these things to a doctor's attention. All right, so let's go back to Janet. So again, we're in our second encounter, 6 months after terminating the first time. And what you've seen is a very strong temporal correlation between the onset of her depression and the onset of her memory problems. So in thinking about all these treatable things, it's like, well, there could be a medical cause, right? She went for a couple of months not taking care of herself. So maybe she's gotten some vascular disease because of that. You ask her about her sleep. Her sleep is poor. And you talk to her daughter with Janet's permission, and you can corroborate this, that she's not having any things that suggest she has sleep apnea. So the things I ask about are snoring and waking up gasping for air. But sometimes even just waking up frequently at night might be a sign of sleep apnea, as well as a lot of daytime sleepiness and napping might raise concerns. So anyway, you ask about all that. Janet doesn't seem to have sleep apnea, so we rule that out. You ask her about all medications and supplements. Are any of them new? Well, yes, it turns out she has been taking Benadryl to try to help her fall asleep at night. So now with your newfound knowledge about medications, you can advise her that she should stop taking Benadryl. And this is also a great opportunity to work with her on behavioral strategies to help improve her sleep so that she can minimize the medications that might cause cognitive problems. So you're considering a cognitive evaluation. So what might that look like? A lot of screeners, well, there's a number of screeners are available that are done in a lot of different healthcare settings. Here's the MOCA over here. Screeners are helpful for staging cognitive impairment, but not determining dementia type. They're just not sensitive enough. The memory assessment is not adequate. This is from the perspective of a neuropsychologist, of course. So you can't determine the type of memory problem that somebody's having. The formal neuropsychological evaluation is best, and it's not just because I am one. But what a neuropsychologist can do is assess cognition in the context of premorbid ability. For example, I saw someone recently who had 6 years of education, and he's 85. So is his cognition normal for somebody with 6 years of education? And so he's not going to may not do as well on a screener because of a history of learning disabilities or things like that. Motivational factors. Sometimes people aren't motivated to do well on testing, and sometimes they're motivated to do badly on testing. So a neuropsychologist can help tease that out. And then importantly, the tests that we have available to us are very sensitive to very early cognitive changes from neurodegenerative disease before anything will show up on an MRI. But I did want to tell you about a couple things you can just do in the office kind of qualitatively without a screener to get an idea about how someone's memory is working. And these are things I do routinely, even though I'm doing a neuropsychological assessment. I actually sometimes put more weight on as much weight on these things as I do on my test results. I always ask about temporal orientation, and I ask about current events. So temporal orientation, I get the date, including the month, year, and exact date. I get the day of the week. I ask for the time of day. So these days in particular, I can tell you it's June 20th just because I've had this on my calendar for a long time. But otherwise, I don't always know the exact date. But if people don't know the month and the year, that's a sign of some disorientation, or they're not making memories to keep up with time. Day of the week in particular, if someone says it's Saturday when it's Tuesday, that's they're not keeping up. You need memory storage to keep up with the date, time of day. If they should know the approximate time of day within an hour or so. With current events, the first thing I ask is, do you keep up with the news? Because if they don't, I can't ask about current events. But if they say yes, and I say, okay, what's going on in the news these days? And it's okay to give them a hint. And I'll give you an example from just a person I saw 2 days ago. She keeps up with the news, watches it every day, what's going on. And she says, well, everything's all about the election, who's running. And she says Trump and Biden. And of course, she could be stuck in 2016. I don't know. That's not all that helpful. But she goes on to say something about Israel. And then she mentions Putin. I said, well, what's going on with Putin? And she's like, oh, something about the war. And I asked, who are they fighting? And she said, Ukraine. And then I go back to Israel. You mentioned Israel. And they're fighting too. Who are they fighting? Hamas. So what you saw there was I had to do a lot of questioning to kind of get some information. But she had a lot of details of relatively recent events. And she had a lot of retrieval problems on testing. So, and she was oriented. So I felt like her brain was making new memories. So having some casual conversations can help. So when you see poor orientation and poor current events, that almost always means there's a storage problem, which will almost always mean it's Alzheimer's disease. All right, so back to Janet in our second encounter. It's now 3 months after you started treating her for the depression after her grandson died, and she's doing so much better. Her depression is greatly reduced. She's back closer to what she seemed to be when you first met her. Her cognition, though, however, her memory is better, but it is not back to where it was when you first saw her. You're seeing the same kind of memory problems. It's an encoding and retrieval type of problem. It's just a lot more. It seems worse than it was when you first met her. Functionally, the good news is, well, first of all, you make some adjustments to your treatment with her then compared to the first time. So she's not the same. So you decide with her that you're going to give her a little bit of memory support. So give her some written information to kind of supplement sessions, repeat the main points, ask her to summarize at the end of the session, what did we talk about today? All those kinds of things will help her take the information in and keep it better. And then the good news is that functionally, she's independent again. She was able to take over her medications again and finances and everything. So she's doing a lot better. So with what's going on now, well, we've gotten rid of the acute cause of some worsening memory, right? The depression is gone, but she still has cognitive impairment. So she might have mild cognitive impairment. You suspect, based on how she interacts with you in sessions, that it's a vascular cause, not Alzheimer's disease. And that would make sense because she didn't take care of her health conditions for a long time. But you think it'd be a good idea now that the depression is lifted to go ahead and get the formal neuropsychological evaluation, because the neuropsychologist can get a clearer picture of what's going on now that the depression has been alleviated. All right. So for the last part of what we're going to talk about today, I wanted to talk about some general things for just working to bear in mind when you're working with older adults. In particular, we're going to talk about communication. And then an area that I think you all will be very helpful with is prevention. All right, so what's wrong with this communication? This is Janet and her daughter are checking in for a medical appointment. The desk clerk asks the daughter, can she sign for the consent? And Janet pipes up and says, yes, I can. And then the desk clerk says, okay, dear, sign right here. All right. First tip when you're talking to older adults is don't make any assumptions. Just because they're with a younger person doesn't mean they're not capable of speaking for themselves. And by the way, that was an actual real interaction I overheard at one of our front desks here, and it was a woman in a wheelchair and a younger person. Just because she's in a wheelchair doesn't mean she's doesn't have the ability to speak for herself. You do want to make some adjustments for normal cognitive aging. So the primary cognitive change that you see, aside from the memory encoding and retrieval problem, is the slow processing speed. And slower processing speed contributes to the memory encoding problem. If information comes at you too fast, you can't process it as well. The solution is to not speak fast. And this is a very important concept that I'm not saying speak slowly, I'm saying not speak fast. So for example, I feel like I have spoken a little fast a couple of times during this presentation, but I'm also slowing down more than, this is not my normal rate of speech. And I do it because the remote setting helps for you all to hear and process what I'm taking. But I'm also very careful to do that when I'm talking with older adults. I'm not speaking slowly like they're impaired. I'm trying not to talk fast. So it just gives a little more time for them to process information and put brief, just a second or two, just brief little pauses in between statements. So there's no need to dumb your language down, speak slower or very slowly. Don't assume they can't hear you just because they're old, and don't use the baby talk, which is elder speak, which you've already learned something about, but basically communication that treats a person like a child or a pet. It's an ageist way to communicate that older persons are just by definition somehow less capable, not as sharp. And the fact is, many younger persons, well, many people speak very quickly, so that's an issue, but many younger persons communicate with all older people as if they have dementia. And you just shouldn't do that. So that's elder speak. Some other adjustments to communication that you do want to keep in mind, though. So one change that does happen frequently with age, especially in men, is hearing loss. What is affected is higher frequency pitches. So women's voices are harder for men with hearing loss, or anyone with hearing loss, to hear. So the solution is you want to pitch, you have to work to pitch your voice a little lower. So I'm speaking lower than my normal volume. I slow down just a little bit. It does require effort to do that, but it really helps. So go low and slow. Make sure there's no background noise. This is important for families. You know, the couple who is always talking to each other in passing, it's like, he's got hearing loss, he's got the TV up loud, and you say, hey, take out the trash. It's not getting in. So you got to take all the background noise away and supplement with writing if you need to. There is no need to scream or shout or automatically direct your speech to other people. I mean, that, you know, especially again, men with hearing loss are at higher risk of depression as well. And part of that is because they start to get left out of things because people direct their conversation to others. All right. So all of that was talking about just a normal older person, and you want to assume that the older person you're talking to is normal until you learn otherwise. So let's talk now about some ways you can communicate with people who do have cognitive impairment. And this is in addition to elder speak to strike from your repertoire, you want to get this sentence out too of, don't you remember? I hear it over and over. It's very hard for people not to say, as family members do it. And you just want to strike that phrase from your vocabulary. So some things you do want to do is really, and this first stage is really important, is set the stage for how that communication is going to take place. You want to approach the person from the front at their eye level, sit down if possible so that you're not hovering over them, make direct eye contact, have your conversations face to face, and make sure, this is particularly in hospital settings, but make sure that lighting is such that they can see you. And if they need glasses and hearing aids, that they have them with them. This is a real problem in hospital settings because a provider or caregiver is standing behind a computer on a pedestal and the patients are not looking at the person at all. You want to be aware of what you say. So you want to introduce yourself and your role, and you may need to do that every time, depending on how much cognitive impairment somebody has. Use the person's preferred name. Always explain what you're doing and why. I was working with somebody the other day who was very upset in her nursing home. They weren't used to dealing. She was a little younger and she was cognitively intact. And they were used to dealing with people who were more impaired, and they were just like, oh, you don't need to know how this works, just do this. And she's like, I want to know. So always say what you're doing and why. Ask one thing at a time. This is also a very hard habit to break. I do it all the time, but people ask run-on questions. Someone was calling me to schedule a Reith appointment, and she was asking questions like, okay, so you don't have high blood pressure, is that right? And I'm thinking I want to answer no to the first question, but I want to answer yes to the second question. And everything she asked me was like two things like that required different answers. And it was like, and I like to think of myself as cognitively intact, but it was very confusing. One thing at a time, give a choice whenever possible. Don't argue, especially with memory loss due to Alzheimer's disease. Don't try to convince them that something happened that they don't remember. Correct the impressions. And what you can do is you want to respond to the affect behind the problem, not necessarily the content. So if someone says, so-and-so stole my purse, you do not want to try to convince them that didn't happen. Just to say, oh, that must be so frustrating, or that must have scared you, or just acknowledge the emotion behind it. And then also be aware of how you say things. So avoid the elder speak. Be attentive to the person's behavior as you're talking. I can sometimes see as I'm talking, you can start to tell it's like, I don't think they are following me. And so I'll stop and do something different. Be patient, allow them more time to respond. Be aware of your own feelings and how they impact care. If you're frustrated, is that coming across in your communication? And including, you have to be aware not just of the words you use, but the tone and that you say them, a facial expression. Smiling isn't always good. You want to show also by your expressions that you're listening and hearing them. A few adjustments for the specific kinds of memory problems that I talked about. The storage problem, which is Alzheimer's disease. They don't remember recent things that have happened. Giving them a hint or a cue is not helpful. That's don't you remember? Don't you remember we just talked about this? That's going to cause, first of all, it's frustrating on both sides. It distresses the person with the memory loss. It will make them suspicious because you keep trying to convince them something that they know didn't happen, and they're going to start to think there's something wrong with you. There's no reason to do that. It doesn't matter. Most of the time, the things that they don't remember, you just tell them again. So they can say the same story over and over again. If they ask the same question over again, they don't remember asking, just tell them again. There's no need to remind them. The encoding and retrieval problems. This person can make new memories, and important information does sink in. And because with the retrieval problem in particular, giving them a little extra context can help bring out the memory. So hints and cues are helpful. Repetitive, they still may ask the same question multiple times, but oftentimes when you give it again, you'll get a little like, oh, all right, we already talked about that. Okay, so that's how to talk with older persons. Now, how do we even just get conversations about cognition started? So this is another problem that that people kind of on both sides of a clinical encounter tend to avoid this. So there's a lot of reasons why a person might not discuss memory loss with their providers. There's a lot of stigma about memory loss. I mean, we're hearing a lot of this with our presidential election with two older individuals and things on both sides about, but there's some mean things being said when, for all we know, they may just be normal for age kinds of things that we're seeing. There's a lot of fear about the consequences of the diagnosis, and this can keep people quiet. I've had people come in. I often ask at the beginning, are you worried that that you have Alzheimer's disease? But I don't always, especially in younger people, like 60s or 50s. And then at the end, they're like, oh, I don't have Alzheimer's disease. They're just so relieved. And I was like, I had no idea they were terrified of that the whole time. I would have told them earlier. But they may not ever bring it up on their own, just too scared. A lot of times what you hear is that, well, what difference does it make? If why should I see a specialist to diagnose this? There's nothing that can be done about it. There's no cure. And if they do bring it up, all it's going to mean is they're going to be sent to yet another doctor or get another prescription that they don't want added on. And I have seen people who've seen 2 or even 3 different providers before they come to me. And then I tell them they need a sleep study because they have sleep apnea, and it's just like it never ends. So people get frustrated. And then most importantly, equally importantly, especially for people with Alzheimer's disease, they may not be aware that there's a problem, so they may think it's normal. On the other side, there's a lot of reasons why providers might not discuss memory loss with their patients. They may defer to patients or family members to bring it up. A lot of times doctors don't go soliciting problems. They expect you to come in and tell them. It can be awkward or uncomfortable if they don't have experience having those conversations, and it can be a difficult conversation. Doctors, not just doctors, but people don't like to give bad news to people. There's also maybe a little sense of helplessness on the part of the provider that there's nobody, depending on where you live, there may not be a specialist to send people to anyway. And then a lot of times I think what's behind that is that healthcare providers, their whole reason for being is to treat people. And so they're not comfortable when they don't have anything to offer. So those are some reasons why the providers might not bring these things up. So how do we overcome these barriers? The important thing, and this is especially as you're working with people who are not even 70 or 80. So for me, my perspective being a geriatric person is old as 80, maybe 78 and up. But having some conversations when people are in their 60s still, or even maybe a little younger, to have some conversations about cognition. And you can start, as always, by asking what matters to the person. What are their thoughts about? I've had people, and the family communication is an important piece, because I've had a family member say, I will never put my mother in a nursing home. And then I'm talking to the mother, and she's like, if I need a nursing home, I need to go in one. I won't care. I'll have dementia. And so sometimes the older person is much more accepting and able to talk, willing to talk about these things than the family member might be. So there's a lot of tiptoeing around, but encourage open family communication. Talk about advanced directives. And a lot of times people avoid this too because they think it's about death. This is what can happen after I die, and they don't want to think about that. But advanced directives are actually about life. It's how you want your life to be if you can't communicate later. So it's not about dying. It's about how do you want to live at the towards the end. So advanced directives are really important to have in place. Be open about limitations of treatment. I'm pretty sure, 20 years earlier in my career, I probably said things like, well, they're coming up with new treatments all the time, if someone has Alzheimer's. And now they ask me, is there any treatment? And I say no. That's the way it is. So I'm open about that. But I also then let them know what a healthcare plan for memory might look like. So we segue off you give the bad, not that you're ever going to be the one diagnosing the dementia, but the bad news is there. You process that. It's like, no, there's no treatment, but there are some things you can do. And the focus then, and this is where I think the counselors and therapists really can play such a vital role, is on prevention. So this is a positive approach to aging and dementia. So we now know that in this country, 41% of dementia cases can be attributed to 12 modifiable lifestyle factors. That means preventable. If they're modifiable, it's preventable. And that percentage is higher in Black and Hispanic Americans. They are at higher risk of hypertension, diabetes, and all those things that cause vascular disease. So the top 4: obesity, inactivity, high blood pressure, hypertension, and diabetes. All of these things, of course, are interrelated with each other, but these are all preventable health conditions. The earlier you you make some lifestyle changes, the better, but it's never too late to derive some benefit from a lifestyle change. And I saw something not too long ago on even when someone is already in the dementia stage, that there can be some benefit to their brain health from making some lifestyle changes. So what are we talking about here? Work with your healthcare providers on managing cardiovascular health. So blood pressure is getting a little high. Okay, let's work on getting it lower before it gets high. Engage in regular physical exercise. Physical therapy may be very helpful in this regard, especially if a person has some balance problems. Following a heart-healthy diet, such as the Mediterranean, well, it's a Mediterranean type diet, but the MIND diet in particular, which you may have heard of more recently, was developed in the Alzheimer's Disease Center at Rush University in Chicago. It's a combination of the Mediterranean diet and the DASH diet, which is the diet for high blood pressure. And what they did is they took the foods from each group that were known to be associated with brain health. So information about that is readily available online. What they found is people who follow the MIND diet moderately reduce their risk of Alzheimer's disease by 35%. If they follow it more closely, they reduce their risk by 53%. So 53. Okay, yeah, 53%. All right, so good news for the MIND diet. Helping people to quit smoking if they're still smoking, adopt healthy sleep habits so they don't need there aren't any medications for sleep that are probably good for the brain or good for cognition and balance. Helping people learn to use hearing loss as a risk factor, as a modifiable risk factor for dementia. So using hearing aids if they're necessary, and staying cognitively and socially engaged. Those are very important. All right, so as we go back to Janet, this is our second encounter, the last few weeks of treatment. So Janet did have the neuropsychological evaluation as you suggested, and she did get diagnosed with a vascular mild cognitive impairment. So your suspicions were correct. And after getting that, so you're helping her process that diagnosis, and in discussing, you decide that the two of you decide that you're going to work together for a few more weeks to help her with some lifestyle modifications to improve her vascular and brain health. I tell all my patients, whatever your doctor says is good for your heart is good for your brain. And this will help reduce her risk of progressing to dementia. And potentially, I mean, this is not a fantasy. I said it earlier that 26% of people with MCI revert back to normal. Janet could be one of those 26%. Her sugar and her cholesterol used to be managed by diet. They could be again, okay? And that could improve her brain health. And so what you're going to do when you're working with her is provide education that she needs, motivation as necessary to make some of these changes and overcome any barriers to adhering to this new plan for her. Okay, so to wrap up, the take-home points, which I'm linking back to our original objectives, is with age, there is some slowing of processing speed and memory encoding and retrieval problems. We learned that MCI and dementia are umbrella terms based on the degree of cognitive impairment that someone has and their level of independence. And there's a lot of different things that could cause them. Alzheimer's disease has the unique memory problem that none of the other types of dementia have, or the vast majority. Causes a storage problem, which is difficulty retaining information over time, making new memories. We learned how to make adjustments in communication that are appropriate for the person we're talking to, not assuming that they're impaired just because they're old, and how to have conversations about cognition early and adopt a positive approach, focus on prevention. And just to take this from the abstract here to the real, for Janet, what this means is you've helped her avoid a misdiagnosis. She could easily have been diagnosed with dementia when she was that depressed. So she didn't get misdiagnosed. You saved her from unnecessary tests and procedures, as well as from medications. So she didn't need an antidepressant. You got her off of Benadryl, and maybe she doesn't need medication for diabetes and high cholesterol anymore. So she's taking fewer medications. You've also reduced her risk for developing delirium in the future. You've helped her retain, actually, and regain her independence and to gave her the tools she needed to reduce her risk for dementia in the future, and basically to be able to live her life according to what matters to her. So congratulations, you had a profound effect on Janet's life. So now we are ready for questions.
Thank you so much, Dr. Musil. This is such, thank you for sharing all the time and knowledge, the expertise with us today. I love how you used a clinical case, to make your points and kind of weave that into your presentation as well. All of this is really critical information, that's going to help counselors and marriage and family therapists work more effectively with older adult clients in their practice, and help aid the practitioners who are beginning to work with this population if practitioners have not been working with older adults. You've provided a lot of information. It's a lot to take in. It's definitely, I'm working my brain very hard to integrate everything, and we'll have to go back and certainly look at the slides to make sure I get all of that information incorporated and that it can stay in my long-term memory. So I do appreciate that. We do have some time for some questions and answers. People have been writing in with a few questions, so I'm going to take some of them. We're not going to be able to get to all of those, but we will get to as many as possible. We have maybe 10 or 15 minutes to get to some of those. So I'm just going to kick these off and let you answer them. And like I said, we'll get to as many as we can.
Okay.
One person wrote in saying, I am wondering how the aging brain and postmenopausal women differ from men. And you're kind of giggling at that, but does this play a role in cognition, and how do hormones play a role? I don't think you addressed that in your presentation, but is that something you could speak to?
No, I didn't. And then the funny thing, I just looked at the Q&A when you were talking. I said, I hope they don't ask me the menopause question
Oh,
because that's why I was laughing, because I am not up on that. There was yes, estrogen does play a role, and I know there was a period of time where they thought that supplementing with estrogen might delay Alzheimer's disease, and it relates to that. It is a little more common in women than men, but I actually don't know. I apologize. I don't know what the current status of that is. The
listen,
problem is that estrogen supplementation increases risk of cancer. So there's a lot of trade-off with some of these conditions.
yeah, of course. And listen, you shared so much information. It's hard to keep up with all of it. And I guess what I would say is there's so many complicating factors, and you did address that in your presentation when you're working really with any kind of mental health, but especially with older adult population, because you have those mitigating circumstances, medications, that kind of thing. So
Yeah,
problem
I
on
think
that.
for me, everybody I see is already way past menopause, so it doesn't always come up. But I do ask about it when they're younger, but I don't know what, in terms of risk for Alzheimer's disease, I don't know the current status.
Okay, yeah, no problem on that. One person wrote in and asked, can the type of dementia be determined from an MRI or from a fMRI? And I'm not even sure what a fMRI is. But could you speak to that?
So a regular MRI is a structural scan. It just says what the brain looks like. And a functional MRI, fMRI, F stands for function. And that is where a person is doing a task and you're trying to look at brain activity, what's active during a particular task. The only kind of scans, so no, a structural MRI will just tell where atrophy might be, but it doesn't tell you what the cause of that might be. So it doesn't say what type of problem it might be. And then functional MRIs are not used clinically at all in a dementia diagnosis. The scans that are being used now we do have some scans now for beta amyloid, and that can help with identifying Alzheimer's disease versus another cause.
Okay, very good. Here is one, and you didn't touch too much on this, but wondering if you can. One person wrote in asking, what are some of the normal or expected cognitive changes for people who already have a history of issues with memory or concentration / executive functioning issues? For example, an adult with ADHD. How does a diagnosis like that impact assessment and or treatment?
And that is a great question, in part because we're seeing, I'd say by the time ADHD awareness has come out, is that I'm now seeing, like 20 years ago, I didn't see older adults who had been diagnosed with, at least with ADHD. Now I'm more likely to be seeing people who have a history of ADHD. Mm-hmm. I will tell you and I'm 64, so from my personal experience of getting older, normal aging is like acquired ADHD. And so I anticipate that as people with ADHD get older, they're going to see their ADHD will look like it's getting worse, if that makes sense. So ADHD is also kind of a frontal lobe issue. It's problems with attention and executive functioning. That's what changes with normal age. And so it is important to know that history and take that into account so that you're not, so someone who has attention and executive functioning at baseline and you see it at 70, trying to figure out whether it's the same level they've always had is a challenge, but that's what we try to do. So anybody, either personally or family members, if you know people and they had a neuropsych eval for ADHD when they were younger, they need to keep it so that they can share it with the neuropsychologist as they get older. Does that make sense? That
yeah,
a worsening of the ADHD symptoms?
Absolutely. And, I know this is probably more lay person to say, but it's sort of that old adage, like whatever you have becomes more pronounced as you age. Do you know what I mean? Whatever, personality or attributes or those kinds of things as well. So this maybe follows along the same lines as that. Really interesting.
Yeah.
Now, here's another question. This person wrote in saying, I've noted a slight increase in legal marijuana use with older clients. And has there been any connection between this and normal versus abnormal aging process?
And I think it's early still to be able to answer that. And I have looked into this, and it's not a clear picture. You'll see studies that say marijuana has a negative effect on cognition, and others that say it's fine. And there's so much variability in marijuana now with the way it's delivered, the potency, the THC versus CBD. I think that research is not there yet to answer that question.
Okay, fair enough.
But generally speaking, substance use is not good for the brain. So alcohol, they're not saying now no amount of alcohol is safe. Especially I think a concern for older adults using marijuana, it depends on the purpose. For one thing, if they're doing something very low dose to help them sleep or to help with chronic pain, versus they're doing it very recreationally to get high, and then might they be at risk of falling or somehow injuring themselves because they have an altered mental status from a substance?
Mm-hmm. Right. So again, the answer is it depends, and it's a little complicated depending on the actual client that is sitting in front of you and what they're presenting with and how they're using the marijuana.
Right. I've seen people. I have a friend who is a full professor at a prestigious university, very smart, and he's smoked marijuana every day of his adult life, and he thinks that's why he's successful. So you have people showing different it's going to take a while to tease that issue out, I think.
Sure. And I'm sure more and more research will likely come out about that.
As it's gotten legal and more people use it, and importantly, being able to report that they use it.
Right. Openly, right? Because some
exactly.
people disclosing that. So again, it goes back to that, barriers and the societal, what is accepted and what's not accepted and what they think they could possibly get in trouble for, that kind of thing as well. Mm-hmm. Okay. Very good. Let's see here. Here's another one that someone wrote in. Are there ways to assess whether difficulty with memory storage is due to MCI, aging, or dementia versus due to an increased stress or mental health issues like anxiety and depression? And you did talk a little bit about that, obviously, with Janet as well, but I don't know if you wanted to expand on that anymore.
Yes. Memory problems caused by stress, anxiety, etc., are not going to be a storage problem. So that's the short answer. Depression does not cause a storage problem. It does. Anxiety does not cause a storage problem. Distinguishing if there is a storage problem, is it normal aging, MCI, or dementia? That's all based on function. So a storage problem is never normal.
Right. Remember you said that.
And so if they have a storage problem and they're functional, it would be MCI. If they have a storage problem and they're not able to do their daily activities, then it would be dementia.
Okay. Very good.
But any of the mental health now, I do want to make a caveat there. As I mentioned, that concept of memory working in stages, that's really important because they go in order. So if you have a problem with the first stage, it's going to affect the others. So if someone has a very bad encoding problem, it could look like a storage problem, if that makes sense, right? Because they're just not taking any information in. And I'll tell you, as a population where this is particularly relevant with is people with significant trauma history and PTSD. If if they're very dissociative, what they are not in the present moment a lot of the time, and so they can look like their memory is very impaired, but it's because they are, the way I explain it to people is, and I should have mentioned this before, mindfulness is one of the most important things you can help people to learn for normal aging. And the way I explain it is that we don't spend a lot of time in the present moment. We are either worried about something that's going to happen in the future or ruminating about something that's happened in the past. And my patients with depression and PTSD, they're nodding along, and they're having anxiety, generalized anxiety disorder. And so what that means is you're not in the present moment. And so you can be running on autopilot, behaving normally and doing things, and you will have absolutely no memory for it. Not because you can't retain information, but because you weren't in the moment when it happened, and so it didn't get encoded. So I see a lot of people with trauma and stress histories who are having a lot, very day-to-day in their function, their day-to-day function is just terrible from memory issues. And they come in, they can do fine on testing, but it's because they're not in the present moment.
Mhm.
And I may have gotten off task on that question, but I think did I answer all of it?
Yeah, you did actually. And I think it's great to bring up mindfulness too. And I wanted to say, I didn't say it then when we came back to the Q&A, is I do appreciate from your presentation focusing on the preventative aspects and some of, the positive information too, what you can do. If you do have a diagnosis or you don't have a diagnosis, the in between, trying to figure out and take care of yourself. And I know being mindful is a big aspect of that as well. So I'm actually really glad you brought that up as a important part of anyone's well-being, really, but particularly for older adults as well.
And I have those prevention conversations with younger people. I'll see someone who has ADHD and they're in their 30s, and I say, just so you know, in about 10 years or so, this is going to get a lot worse, or it may get worse. And it's about the people who struggle the most with normal age changes are the ones who don't make adaptations for it. So they hold themselves to the same standards they had for themselves when they were younger. Those are the people who struggle the most with just getting older. Well, I always used to be able to multitask. And I said, well, you didn't used to be 75, so you shouldn't be multitasking. And so if you continue to try to do things the way you did when you were younger, that's when they have memory failures. You just have to make some adjustments. Do one thing at a time.
Well, of course, we're always the hardest on ourselves, correct? So giving yourself grace and kind of being comfortable with any stage of life that you are in and being kind to yourself can always be a problem, of course. So thank you for mentioning that too. Mm-hmm. We have one more question that my team has sent to me, and I want to end with this one because several people are asking, and then we're going to have to unfortunately wrap up. We're running out of time. Several people have written in and they're asking for additional options to tell clients who can't get in with a neurologist or a person such as yourself because of where they live, if they're on a long wait list. Do you have any tips, or can you share any knowledge with people that are having trouble getting, connected with a specialist or, because of where they live, that kind of thing?
I guess for what problem? Like, what are we talking about? Concern for dementia, or?
Yes, I think it would be any of it, probably the mild cognitive impairment or dementia, or just not knowing, like not sure, not having a diagnosis maybe yet, but knowing that something else may need to occur and they may need to see a specialist, but are having trouble connecting with one. And I think this is probably more about, it's like a resource question for people, obviously, who live in.
Well, that's why it's so important that this group is being able to work with older adults now.
Exactly.
So I think doing some things to asking those questions at the beginning to try to, obviously you're not diagnosing things, but you could say like, hey, you know what? It sounds like you might have sleep apnea. and then supporting with the prevention stuff. Let's talk about while you're waiting, let's try to make some of these changes, see if this makes a difference. And in particular, if you're working with somebody for depression and anxiety, it is always possible, whenever that's present. I'm almost always going to say that could be contributing. So you can chip away at the things that you know might be contributing while you wait to find out what's underneath.
Very good. And I think that's a great answer. And you shared some of that, very practical things that can be implemented immediately. So I think that is great. So thank you. Unfortunately, we're at the top of the hour. It's 2:00. So we're going to have to wrap up and we don't have time for more questions. But the Medicare Mental Health Workforce Coalition and MBCC, we would like to thank you, Dr. Musil, for sharing your knowledge, and all the participants that attended today's webinar. It was very well attended. So thank you to all of you that took time out of your day to attend. The link to the session evaluation is posted in the chat or in the Q&A box, and we will also email it to you following the meeting. To receive continuing education credit, you must complete the evaluation, including an attendance attestation by July 8th at 5 p.m. Eastern time. Certificates will be emailed by July 15th, so be on the lookout for those. We will only be providing credit for the live attendance of this webinar. We certainly hope you found this session informative. I know I did, and we look forward to seeing all of you again in the future as we continue our Medicare webinar series. So please be on the lookout for upcoming webinar dates and topics. Thank you, and everyone have a wonderful rest of your day. And thanks again, Dr. Musil, for joining us. We really appreciate it.
You're very welcome. Thanks for having me.
Sure.